Probe position and orientation for transesophageal echocardiography, or TEE. The principles of this procedure include probe insertion, probe manipulation, and image display. Insertion is done by 1. Displacing the mandible anteriorly and inserting the probe gently in the midline, or 2. Under direct laryngoscopic visualization. Some important points to note about insertion are 1. Never force the probe. 2. The tip of the transducer is in neutral position. 3. The control wheels are always unlocked. And 4. Suctioning of gastric fluids and air improves the visual quality of the images. Excessive force must never be applied. A patient in whom the TEE probe does not pass into the esophagus is not a candidate for this procedure. There are 4 ways of manipulation. 1. Advancing and withdrawing the probe. 2. Antiflexion and retroflexion. 3. Lateral flexion to the right or to the left. And 4. Axial rotation. For the image display, by convention, the transducer location appears at the top of the images, with the near field at the top and far field below. At 0 degrees, the image is directed anteriorly from the esophagus to the heart. The patient's right side is presented on the left side of the image display. Rotation of the crystal from 0 to 90 degrees is counterclockwise, with the TEE probe tip as the clock face. There are several challenges with this procedure. First, the heart is beating and there is translational movement with breathing. Second, there are different axial rotations of the heart. Third, all the cardiac structures are at different orientations and angles to each other. And fourth, complete cardiac examination includes 1. Two-dimensional imaging to examine the cardiac anatomy. 2. Color flow Doppler imaging to visualize blood flow velocities. 3. Pulse wave to measure blood flow velocities at specific locations. And 4. Continuous wave to measure high velocities that exceed the limits of pulsed Doppler and are commonly associated with abnormal flow jets. Most importantly, the heart is a 3-dimensional structure with anterior and posterior surfaces and left and right margins, and we have to appreciate it in a 2-dimensional way using TEE. First, aorta and pulmonary arteries are at right angles to each other. Second, pulmonary veins are parallel to the base of the heart. And third, the superior and inferior vena cava are at right angles to the base of the heart. As we can see, the heart was not designed for TEE examination. The body has planes that are at right angles to each other, while the position of the heart does not follow those planes. So, the orientation with TEE has to be adjusted to evaluate the anatomy. Conventionally, the image displayed is upside down and rotated left to right, so the left-sided structures are on the right side of the screen. The left main bronchus is anterior to the arch of the aorta, so it is not possible to assess the ascending portion of the aorta. There are variations between individuals in the anatomic relationship of the esophagus to the heart. In some patients, the esophagus is adjacent to the lateral portion of the atrioventricular groove, while in others it is directly posterior to the left atrium. This relationship must be considered when developing a particular TEE view. Each structure should be examined in multiple imaging planes and from more than one transducer position. Here is an image of the TEE probe controls. Turning to the right is rotating the anterior aspect of the probe in the esophagus toward the patient's right side. Turning to the left is rotating the anterior aspect of the probe in the esophagus toward the patient's left side. Advancing the transducer is pushing the tip of the probe more distally into the esophagus or the stomach. Withdrawing is pulling the tip more proximally. Anti-flexing is flexing the tip of the probe with the large control wheel anteriorly. Retroflexing is flexing the tip of the probe with the large control wheel posteriorly. Flexing to the right is flexing the tip of the probe with the small control wheel to the patient's right side. Flexing to the left is flexing the tip of the probe with the small control wheel to the patient's left side. Rotating forward is adjustment of the transducer multiplane angle from 0 degrees to 180 degrees. Rotating backward is adjusting in the opposite direction to 0 degrees. This video clip demonstrates TEE probe manipulations. The large wheel controls the flexion and anti-flexion, while the small wheel controls the side-to-side motion. Turning to the right rotates the anterior aspect to the patient's right side, while turning to the left rotates the anterior aspect to the patient's left side. This picture shows the setup of the tool. An echocardiograph produces a two-dimensional image or slice through the heart. Moving the imaging plane through the three-dimensional extent of a structure by manipulating the probe is necessary to examine each structure in its entirety. This process is done by advancing and withdrawing the probe in the esophagus for the more horizontal imaging planes, i.e. multiplane angles close to 0 degrees and 180 degrees, and by turning the probe to the patient's left and right sides for the more vertical imaging planes, i.e. multiplane angles close to 90 degrees. The imaging plane can also be moved through a structure by placing it in the center line of the image, holding the probe still, and increasing or decreasing the multiplane angle. It is best to focus the examination on one structure at a time, after the same sequence in each study. To review, the upper esophageal views are obtained at a depth of 20 to 25 centimeters from the incisors. The trachea, bronchi, and great vessels are visible at this level. The aorta and pulmonary artery are the structures most often evaluated here. The mid-esophageal level is seen at 30 to 40 centimeters and provides much information about all chambers and valves. Rotating the omniplane angle from 0 to 135 degrees reveals most cardiac structures of interest. Valves can also be interrogated with pulsed wave and color Doppler at this level. Further advancing the probe into the stomach gives transgastric images of the heart at 0 degrees and 90 degrees. What you can see are the right and left ventricles, the mitral valve, the aortic valve, and the tricuspid valve. From these, issues that can be answered are hemodynamic assessment, LV hypertrophy, LV enlargement, LV systolic function, both regional and global, mitral valve apparatus assessment, and cardiac output and stroke volume. The tip of the TEE probe has crystals in it. The counterclockwise movement of the crystals changes the angle from 0 degrees to 180 degrees. The complete assessment includes segmental assessments of all the 17 segments of the heart at each level and valvular assessment. The technical skills related to echocardiographic data acquisition are ultrasound system adjustment and transducer manipulation. It is important to master the transducer manipulation as this is the key to good examination. Two important aspects are the probe position and crystal position, and it is a combination of both that is needed for a comprehensive examination.